Thank you so much for having me here today to discuss a little bit about the role of surgery in the treatment of your melanoma. And as Jen said, I'm a surgical oncologist at MD Anderson, and I focus on the treatment of skin cancers and soft tissue sarcomas. I have no disclosures. So as the other speakers alluded to, the prognosis of a melanoma patient depends on the stage of the melanoma at the time of diagnosis. And in general, the lower stage that your melanoma is at diagnosis, the better your prognosis. And here I show some survival curves of patients in a population of a large number of patients, and what percentage of those patients survive at 5 years and 10 years, depending on their stage of melanoma disease, with higher stage disease having lower 10 and 5-year survival. So these are the survival curves, and I'm just showing from the 8th edition international cohort of patients in this data set. Patients with lower stage melanoma do better at 5 and 10 years compared to those with higher stage 3 melanoma. So the melanoma staging system categorizes patients with melanoma into staging groups that are prognostic of their outcome based on features of their melanoma. And these include the thickness of the melanoma, as well as whether there's presence of ulceration in the primary melanoma. It also includes information about whether there's melanoma that's already spread to the lymph nodes and how much melanoma has spread to the lymph nodes, and whether this patient has melanoma in other organs in the body besides the lymph nodes. So when I'm in clinic seeing a new patient, I often have this chart handy because even for me, I find that the melanoma staging system can be a bit overwhelming and it's difficult to memorize. But in general, for patients whose melanoma is only located in the site where it started, those patients are typically stage 1 or stage 2 melanoma. Those where the melanoma has spread to the lymph nodes already have stage 3 disease. And those where the melanoma has spread to other organs aside from the lymph nodes have stage 4 disease. And even within stage 1, stage 2, and stage 3 melanoma patients, there are subgroups of patients, so that if you look, for example, at the right panel, even for patients with stage 3 disease, there's very different outcomes depending on what kind of stage 3 disease you have. So what is the role of surgery in your melanoma treatment? I would say that surgery is pretty important for the treatment of most patients with melanomas. For those with early stage melanoma, it can often be the only treatment you need and often is curative. And then for patients with stage 3 melanoma, it's a necessary part of the multidisciplinary care of your disease. Although I focus in this talk on the treatment of stage 1 through 3 melanoma, as others discussed, it is an important point that surgery might have a role for patients with advanced or metastatic melanoma. Sometimes these are patients who are looking for a surgeon to remove some tumor in order for adoptive therapies to be grown and produced for their treatment. Other times it's patients where they have melanoma that's metastatic and causing symptoms like pain or bleeding, intestinal blockage, or wound issues that we could help with. And then there are a few limited circumstances where somebody might have that oligometastatic melanoma, a couple lesions that haven't changed over time that a surgeon might consider removing in a surgery. So as a melanoma surgeon, oftentimes I'm meeting patients who are referred to us to be seen after they've been diagnosed with a melanoma by their dermatologist or their local physician, and they've undergone a biopsy of their mole. It's important for us to review the pathology ourselves, and so we'll always request that the slides from their dermatologist get sent to MD Anderson for our pathologist to review, and the features that we see in this melanoma biopsy sample will guide our treatment recommendations. And so we look at features of how aggressive that melanoma might be and its likelihood of spreading to the lymph nodes or other organs. When we meet you, we'll perform a physical exam and a history. We're focusing on the skin exam to look for other lesions that might be concerning for other skin cancers, or any lesions that might be suspicious that the melanoma may have already spread to other parts of the body. Based on the biopsy results and the exam, we might recommend some other imaging scans like ultrasounds or CT scans before we decide to proceed with an operation. So there's two potential outcomes from our exam. There first may be on our exam, we may find no evidence that the melanoma has spread to other parts of the body, including the lymph nodes. And in this case, we would typically recommend proceeding with surgery. The goals of surgery are twofold. So the first is we want to make sure that the melanoma is removed completely and to decrease the risk of the melanoma coming back. The second is in patients where we think that there is some risk of the melanoma having spread to lymph nodes in microscopic amounts, and that's typically for patients where we think the risk might be anywhere from 5 to 8% or greater. Then we may recommend sampling the lymph nodes to see if there's any disease in the lymph nodes. And melanoma that's spread in microscopic amounts to the lymph nodes is such that we can't identify these abnormal lymph nodes by exam alone or on scans. And so the only way to tell is if we can sample the lymph nodes and send those to the pathologist to review under the microscope. And this procedure is typically offered to patients whose melanomas are greater than 0.8 millimeter in thickness, or patients whose melanomas are thinner than 0.8 millimeters, but may have other adverse features like ulceration or multiple dividing cells under the microscope. When we treat a melanoma, this is performed in a procedure called a wide excision. And this basically is where the surgeon or the dermatologist will remove the site of the melanoma with the biopsy scar and any abnormal pigment and a rim of normal looking skin around the biopsy and melanoma. And this is called the margin. And we take anywhere from 0.5 centimeter to 2 centimeters of normal appearing skin around the melanoma based on how thick the melanoma was on the biopsy. So the thicker the melanoma is, the larger the recommended excision margin. So typically for melanomas a centimeter or thinner, we would remove 1 centimeter of normal skin in all directions around the melanoma. For melanomas that are 1 to 2 millimeters in thickness, we would target 1 to 2 centimeters of skin excision around the site of melanoma. And for thicker melanomas greater than 2, we would try to get 2 centimeter margins. But it's important to recognize there are some parts of the body where we can't get 2 centimeter margins, for example, like the head or the face, the hands and feet. And sometimes we have to adjust the size of the margin based on where the melanoma is located. So here's an example of a melanoma and biopsy scar, and then a diagram of the margin that we need circumferentially all the way around the melanoma. And so typically to treat a melanoma, a circle of skin is needed to be removed around the melanoma site. But if you imagine a wound that's a circle, it's very difficult for the surgeon or dermatologist to close this into a straight line scar. You'd end up with bunching and extra tissue at the ends. So what we typically do is we remove an ellipse of skin so that we can close the wound in a straight line. And typically the dimensions of this ellipse is usually it's about 2 to 3 times longer than it is wide. The orientation of this ellipse of skin that the surgeon will remove is really important. So in order for the surgeon and or the dermatologist who's performing this excision to have the best chance of the wound healing well, they need to orient this ellipse in a way so that there's the least amount of stress and tension on the wound. And so for melanomas on the arm or leg, for example, we will orient this ellipse along the length of the limb and not transversely or perpendicular to the length of the limb. That ends up with problems if you later need a new surgery. The blood supply to the skin and the tightness of that closure is are gonna be problems in this circumstance on the left side. The other question that we often get is how deep do we go? So when we remove a melanoma, we take full thickness of the skin at that area. We take all of the fat underneath the skin down to the surface of the muscle at that part of the body, but we don't take any of the underlying muscle. It's important to know that there's some parts of the body, like the hands and feet, like the shin, where there's not enough loose tissue, loose skin to be able to close the incision directly. And so sometimes your surgeon may close the wound with plastic surgery techniques to try to recruit extra skin from other parts of the body, or they may use a skin graft or a temporary wound dressing, or they may involve a plastic surgeon colleague to help close the wound. I had previously mentioned that for patients with at least a 5 to 8% chance that the melanoma may have already spread to lymph nodes, that we would discuss and offer a lymphatic mapping and sentinel lymph node biopsy, which is a procedure to sample the lymph nodes and see if there's any microscopic cells of melanoma present in the lymph nodes. So this is a procedure that is typically done at the same time as your melanoma surgery. What we do is we inject the tumor with 2 dyes. One is typically a blue dye and the other one is a radioactive dye. It's a very low amount of radiation. You don't have to do anything special in terms of you're able to interact with your family. You don't need to use separate bathrooms. On the day of surgery, we inject these 2 dyes into the location of the melanoma. These dyes travel along the lymphatic channels to the draining lymph node basin. And then at the time of surgery, we use a handheld probe to listen and look for the lymph nodes that see the dyes. And the first lymph nodes that take up the dyes are the ones that are most likely going to contain melanoma if the melanoma has spread to the lymph nodes. This inset here on the bottom right is a picture of an example of one of these sentinel lymph nodes that's picked up the blue dye, and you see the little blue lymphatic channel draining or bringing fluid to that lymph node. These sentinel lymph node biopsy procedures are typically performed through small incisions, usually about 2 to 3 centimeters long, and closed with all dissolvable stitches under the skin. For melanoma of the arm, typically the draining lymph nodes, the sentinel nodes, are going to be located in the armpit area or the axilla. For melanomas of the leg, the draining lymph nodes are typically in the groin or the inguinal lymph nodes. And for melanomas of the trunk, which is the back, the chest, the abdominal belly skin, or the flanks, the drainage pattern can be very different from person to person. So the surgeon will need to send you to the nuclear medicine department, which is a part of the radiology department, to do the lymphatic mapping procedure before surgery so that we can plan how you're going to need to be positioned during the operation in the operating room. So for example, a melanoma on your chest, the lymphatic fluid could drain to either armpit areas or either groins or somewhere in between. And so it's helpful for us in planning the surgery to do the lymphatic mapping beforehand. I spend a lot of time in clinic talking to patients before surgery about what to expect after their operation. And with any operation, any invasive procedure, there are potential complications. And so I discuss with them the potential risks of bleeding, of wound healing issues. When the incision opens a little bit, that's called a wound dehiscence. It's also possible to have an infection when the lymphatic fluid collects under the skin, either at the site of the lymph node sampling procedure or at the site of the melanoma removal. That's called a seroma. Sometimes nothing needs to be done for that. Sometimes that fluid needs to be drained out in a clinic procedure. With a surgery and an incision, there is always going to be some residual skin numbness. Sometimes this is permanent. Sometimes it gets better over the first 6 to 9 months after the operation. But oftentimes the skin never quite feels the same as before an operation. With the lymph node sampling procedure, the risk of limb, arm, or leg swelling is fairly low, but it's not zero. And that's called lymphedema. This is due to impaired or altered drainage of lymphatic fluid out of the arm or leg back to the rest of the body. And that's typically managed with compression garments, and some folks will have a lymphedema pump that we have set up for them. But this is usually more commonly seen after a more extensive lymph node procedure that I'll talk about in a little bit. At our institution, after surgery, our pathology results are typically available within a business week. Depends if we have any lymph nodes to look at. When we send sentinel lymph nodes for the pathologist to review, that usually takes them about a week to look through. They look through those lymph node tissues very carefully so that they're able to tell us if there are a few cells seen within that tissue. And what we're looking for in the pathology report is we want to make sure that there's no melanoma left behind at the edges of the tissue that we removed. And we want to make sure to know if there's any microscopic melanoma seen in the lymph nodes. If there's melanoma present within the lymph nodes, then your surgeon will refer you to meet a medical oncologist, and then the team would have a multidisciplinary discussion about what whether you need further treatments and what your options might be. And these options might include adjuvant or postoperative drug therapy, another surgery to remove all of the remaining lymph nodes in that nodal basin, which is a procedure called a completion lymph node dissection. Or if the team feels that the risks of these procedures are too high, or that your risk of melanoma coming back is very low, we may recommend just observation and exams every 3 months. Now let's go back to the situation where we're meeting the patient or you're meeting your surgeon for the first time, and on our exam, we find an enlarged lymph node or a hard lymph node, or you find an enlarged lymph node or hard lymph node on exam or on a scan. In this situation, we're no longer concerned about microscopic disease in the lymph nodes. We're worried that you have what we call clinically evident lymph node disease. And so we typically refer you for a biopsy of the lymph node. If we see melanoma is present in the lymph node, then we'll get additional imaging to make sure that there's no melanoma in other organs in the body besides the lymph nodes, and that may include CT scans, brain imaging, and then we would also get other testing of the melanoma. And then at this point, we would have you meet with our medical oncologist. At MD Anderson, as Dr. Amaria discussed, we are often considering whether or not you might be a good candidate or interested in participating in a clinical trial of neoadjuvant therapy or preoperative therapy. And then, currently, what is standard of care in a lot of places is to proceed with surgery to remove all the lymph nodes in that nodal basin. And in this circumstance, that lymph node procedure is called a therapeutic lymph node dissection. And if the melanoma is present, then you'll also at the same time need the melanoma removed. So I listed here some common questions that, most of the time I think our team will address these questions, but if not, these are other good questions to have on hand to ask your melanoma team. And then specific questions for your melanoma surgery is, patients will often ask how long the procedure will take, is it a day surgery, or will you need to be admitted to the hospital? In general, for removal of the melanoma and a sentinel lymph node biopsy, those are typically day surgeries. If you're having all of the lymph nodes removed from either the armpit area or the groin, that's usually a 1 or 2 night hospital stay. I'm happy to take any questions at this time.